Welcome again. It's me, Malcolm Bell. I'm your studio host for today, and this is another in the Mayo Clinic series of interviews with the experts. Our topic today is the management of aortic stenosis in the younger patient. And very, very fortunate and delighted to have with me my colleague, Dr. Mac Lead, who's a professor of medicine. He's an interventional cardiologist. He's also a practice chair in the cardiac cath lab. But his particular expertise is in the area of transcatheter valve interventions. And this is one of two episodes that we're going to record. But let's start with aortic stenosis and Mac, really delighted to have you with us today.
Thank you very much, Malcolm, for the invitation. It's my pleasure to be here, especially talking about these really exciting topics. I think it's very timely, this discussion. So.
Yeah. Well, just as a little background, of course, I mean, TAVR, transcatheter aortic valve replacement or intervention has really revolutionized, hasn't it? The management of severe aortic stenosis, particularly in the older patients. As expected, I mean, the results have been very, very good in terms of comparing to surgery. But understandably, there's been some sort of creep downwards in terms of how young could you really intervene with TAVR in these patients. And I think it's only natural that any patient and younger patients would rather have a non-surgical intervention of their valve. So, with that as a background, maybe just tell us when we're talking about the younger patient, how young are we talking about, and then maybe we'll go from there.
That's a really good point, Malcolm, because we always think of aortic stenosis as a disease of aging, degenerative calcific aortic stenosis. So by definition, most of the patients are older, but there is a group of patients who are younger, and that's what there's increasing interest in what are the best treatments for them. For one thing, we know the bicuspid aortic stenosis patients is included in that group. About 2% of the population has a bicuspid aortic valve, and then some of them will develop aortic stenosis, and typically at a much younger age than a trileaflet aortic valve. So that's one of the groups, and we're talking people presenting in their 50s and 60s rather than in their 70s and 80s, which is when the calcific aortic stenosis patients typically will present with severe disease.
So for today's discussion, I mean, should we maybe just think about that younger patient being someone, let's say, under the age of 65? Is that a fair place to start here?
Yes, I think that's a common cutoff that we use. Yep.
Okay. And as a surmise, any patient would prefer probably to have a non-surgical approach if it was deemed appropriate. But as we think about that, I mean, we've had a lot of randomized trials of surgical aortic valve replacement versus transcatheter valve replacement or intervention. What randomized trials can help inform us about how a non-surgical approach measures up to the traditional surgical approach, which may be a bioprosthetic valve, and particularly in the younger population, maybe even a mechanical valve?
Yes, I think that's currently a hot question. All of the existing randomized trials were in patients that were average age of 70 or higher. So even the low risk TAVI trials were in the mean age was in the low 70s, and in those in Partner 3 and also the Evolut trial. So the 65-year-old and younger patients really have not been represented in those trials, but we do know that durability is similar between the transcatheter aortic valves and the surgical tissue valves so far in the 5 to 10 year follow-up that we have from randomized trials like Notion and Partner 3. So that's reassuring in terms of the durability, but we still have to answer the question, is a mechanical prosthesis better for each individual patient that we're talking to? And,
We'll come
and
back to the mechanical valve here in a moment, but um, I mean durability, to someone in their 70s or 80s, I mean that means something very different, compared to someone who is 60 years of age or 50, and obviously we don't have that long enough, follow up. But you mentioned Notion, and as I understand it, the Notion 2 trial, when they compared it, because you've already talked about bicuspid aortic valves, and that was in the younger patients, and it seemed to do pretty well against surgical aortic valve replacement, but perhaps except for the bicuspid aortic valve group that you had mentioned. Can you speak to that?
yeah, I think, that wasn't really powered for the bicuspid AS patients, a Notion 2, and that's one of the reasons why there are dedicated bicuspid AS clinical trials that are going to be starting very soon. One of them is Believers trial. That's the US one, and there'll be another one as well that's based in Europe primarily. But these are going to be large multi-center randomized trials with, and this is another thing that's been missing in other trials, is CT phenotyping of the bicuspid disease, because that is a huge factor in having a core lab looking at the anatomy and categorizing what type of bileaflet valve or bicuspid valve is it. Is there a raphe? Is the raphe calcified? Are the cusps symmetric? What is the asymmetry of the calcification? Those are such huge factors when we're looking at an individual patient and thinking about if a transcatheter valve is suitable for them.
So that sounds that would be very, very important, particularly in this younger age group, to really choosing the right valve. Coming correct, and any other factors that you take into consideration when you're trying to work out the best management in these younger patients?
Yes, the other important thing is planning for a second valve. If we're going with a tissue valve and not going with a mechanical valve, we have to look at the entire aortic root anatomy and then have a virtual transcatheter valve overlaid and see what is the prospect for a valve in valve, because we have to assume a younger patient will come back and need a valve in valve when that valve degenerates. So we're getting pretty used to that whole process in our decision making with patients and discussing which valve would be best suited to allow for that in the future.
So Mac, I mean, you and I understand what a valve and valve is, as many cardiologists, and certainly interventional cardiologists. But I suspect we've got many listeners that may be sort of a new concept, valve and valve. So perhaps you could just explain what that means, particularly in terms of your planning for long-term outcome here. So you've got a patient who's going to have a procedure, and then you're already talking about a valve in valve. And so maybe you could just explain that, because that's clearly a pivotal point in time, isn't it, in terms of what you're going to be doing with that patient now and possibly in the future?
Right. So valve in valve refers to placing a new transcatheter valve inside of an old valve, either an old surgical valve or an old transcatheter valve that has degenerated, either due to stenosis, narrowing, or regurgitation. And we know that you can do valve in valve in most transcatheter valves, similarly to surgical valves. But where we run into concerns are if the aortic root anatomy is more small and our coronary flow could be limited. That's one issue. The other one is patient prosthesis mismatch, which means a valve is too small for a patient. And then so they end up with some element of stenosis even after they have a new valve put in. So we have to factor all of that in to decision making and planning.
And you talked about durability, and we know that bioprosthetic valves, whether they're surgically placed or TAVR, but certainly from the surgical experience, at some point they do start to degenerate. And so if you're talking about valve and valve potential with a patient who really does not want to have surgery to start with, um, what would be the expected time frame that you might be anticipate that may become an issue? And the second question is, once you start doing valve and valve, what's the prognosis in those patients in terms of durability?
Mhm.
They need a third procedure.
Right. I think what we've learned recently, there's increasing studies looking at valve expansion and how that relates to durability. And so the better expanded we can make the transcatheter valve, the better the leaflets will work in terms of their motion and excursion. And it appears that that is related to clinical outcomes, including repeat intervention and even survival. So when we're placing the transcatheter valve, we have to make sure it's going to be well expanded. So sometimes that means actually placing a smaller sized valve that and adding volume, or just to ensure that it does not have severe underexpansion. But is in terms of the exact durability, we don't have quite as much long-term data with valve and valve as we do with native TAVR yet. But so far, it seems to be comparable as long as it's not an underexpanded valve.
Or staying with that younger patient and thinking about, who would be better off having a surgical valve, procedure. And also, it's perhaps a very concerning, and I'm sure you're familiar with, the observational study from Cedars-Sinai, was 30 or 40,000 patients. And these were patients under the age of 60 or so, or around about 60, but like half those patients then wanted to actually have TAVR, and actually were having TAVR. And so I'm just curious what your response was, to those findings. I mean, it was obviously, and they did not do, as I recall, did not do quite as well as the patients who had surgical valve replacements. And so getting back to the question then is, who should have surgical aortic valve replacements at that age? And how concerned are you about doing TAVI or TAVR in these younger patients?
Hmm. Yes, I think we have seen from many observational studies that if you have a bicuspid aortic valve, then there are less good technical outcomes with TAVR than with a tricuspid valve. There's slightly higher rates of paravalvular leak, pacemaker, and even stroke in some studies have shown it's slightly higher with a bicuspid aortic valve. Um, so we don't, though, have head-to-head, randomized trials between bicuspid TAVR versus surgery. And so it has to be a tailored approach based on the patient's anatomy. Of course, if there's any indications for surgery outside of the aortic stenosis, then that's a more obvious choice for surgery, such as an aortic aneurysm. Um, and and that will be excluded from these randomized trials. It's going to have to be a patient that could be treated with TAVR and does not have any other surgical indication. Um, so I think that, and then the mechanical valve question is a big question that has to be decided up front with patients about their ability to take anticoagulation, how that works with their lifestyle and other comorbidities as well.
I mean, Mac, you're seeing a lot of these patients, and I'm sure you're seeing a lot of young patients, who have the need to have, valve replacement. And so I'm just curious in your experience of what are patients really asking you? I mean, let's say it's a 62-year-old man with severe aortic stenosis, and let's say it's not a bicuspid aortic valve. And so how do you navigate that with the patient? What be your recommendations? And is it easy? Well, probably not, but in terms of that discussion about surgical valve versus TAVR, and if it's a surgical valve, is it going to be bioprosthetic? And that's when you're going to start talking about valve and valve in the future versus mechanical. So I'm just curious. I mean, people want to avoid anticoagulation, don't they? But
They do.
faced with those patients, and their longevity is, still very reasonable. How do you navigate those discussions with the patients?
Right. I think in a patient in their 60s, you could estimate, 20-year longevity potentially, depending on comorbidities, although that's a very rough estimate. But we have the discussion number one, as you said, about anticoagulation. And are they interested in a mechanical valve? That the durability is better with a mechanical valve. But it comes at the annual cost related to long-term anticoagulation. And luckily, we also have our surgeons with us as well during these conversations. So the patient meets with us at the same time essentially, so we can help them make a decision. But more and more patients do prefer TAVR as we see more and more outcomes showing the safety of it, the durability of it. Most patients do prefer a tissue prosthesis to avoid the anticoagulation. So, and that's one reason why we are seeing TAVR becoming even more common than isolated SAVR now. We're doing more TAVR in the United States than isolated surgical AVR.
And that's with their knowledge that it's quite possible they're going to require a valve-in-valve procedure sometime down the line.
Mm-hmm.
Okay.
Right.
So maybe as we wrap up here, Mac, are there randomized trials really focused on this population now, this young patient, and would those include mechanical valves in the surgical arm? And the second question is, do we have guidelines, how to manage these younger patients?
Yes, I believe that the upcoming randomized trials are going to address this very question. So one of the ones that I mentioned, the Believers trial, that's going to be starting very soon, and that's a multi-center randomized trial between TAVR and surgery for bicuspid aortic valve patients, and it does include the option for a mechanical valve. Um, so that'll be and you can use any kind of transcatheter valve in that study as well. So we're really looking forward to seeing that as well. Now, it has to be a patient that's deemed to be suitable at least for a bioprosthesis. So that's one of the inclusion criteria. Um, so uh, Now the other ones, I'm not sure exactly how the design is going to be. And there's other plans for just TAVR in young patients as well, but that hasn't materialized just yet. So we'll have to see what
Sure.
comes of that.
Maybe one question which we haven't, the one topic we haven't really covered. You talked about some of the other things that there are concerns about. Whether it's a stroke, need for pacemakers, is future access to the coronary arteries. With these valves, and I'm sure that you've probably got some strong opinions about what valve should be placed in these younger patients who may yet develop a coronary disease in the future that may require intervention.
Yeah, I think the self-expanding valves have been more challenging for coronary access. Now the latest generation now has larger windows for coronary access, which helps a lot. But it still can be a challenge. And the other issue with that is just that the valve itself is supraannular. So then if a patient has narrow sinuses, that will be more of an issue for valve-in-valve if those leaflets get pinned. But we do now have devices to lacerate the leaflets to facilitate valve-in-valve. So that's become that's a nice thing to have now to allow for coronary flow for valve-in-valve. So I think we do prefer the balloon expandable valve because of coronary access and also lower pacing risk. But it's nice to have all the options available for different anatomies.
So in closing, Mac, what would be your message to cardiologists and whether they're interventional or valve experts in terms of what they should be discussing with these younger patients in terms of the options for treatment of their aortic stenosis?
Yeah, I think number one is suitability for anticoagulation. What is most important to the patient? Is it avoiding repeat interventions, which would favor a mechanical valve and long-term anticoagulation? Or is it a very young patient that should be seen at a congenital heart center of excellence to discuss other options, including a Ross procedure, which could avoid that need for anticoagulation? And then if they're going with a bioprosthesis, then it's a very even discussion between TAVI and surgery for those patients. And it's really going to come down to the anatomy of the valve, how suitable it is for TAVR, and how suitable it will be for a future valve-in-valve when they eventually need that.
Okay. Well, these must be challenging discussions with the patient. Obviously, we work and you work closely with the surgeons and share decision making with the patient. But I think we'll probably have no more time here for any further questions here. But I think you've really provided us with a really good view of where we are and what we don't know of in the future, and particularly in terms of durability. So, Mac, I really want to thank you for being with us today and sharing your experience and expertise.
Thank you as well, Malcolm. Enjoyed the discussion.
We hope that you'll be joining us again for another episode in our interviews with the experts. And I'll be shortly having Dr. Elite again with us to talk about tricuspid valve replacements that are transcatheter. So hope you'll join us when we do that. So thank you very much.
At Mayo Clinic, continuous learning fuels world-class care. I am Dr. Francisco Lopez Jimenez, Chair of the Division of Preventive Cardiology. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Please check out the link cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who have already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.